So welcome to episode 12 of the Lister webinar series on COVID-19 infection. Thank you to TJ and Joe for inviting me to speak on rheumatology topics in the context of COVID-19. My name is Maureen Joy and I've trained at the Lister as an SPR and now work here as a locum consultant in rheumatology and general medicine. I would like to thank Dr. Bharti Vijayakun, consultant rheumatologist, for his input into this presentation. So the objectives are, firstly, I'll go through a couple of cases looking at how to approach a patient with autoimmune rheumatic disease, presenting with COVID-19 symptoms. Then I will talk through risk stratification for shielding, touch on any cautions with regards to steroids and NSAID use in our normal rheumatology cohort. I'll go through DMARDs, or disease-modifying anti-rheumatic medications, now being used in trials for patients with COVID-19, particularly hydroxychloroquine and IL-6 inhibitors. I'm going to talk through the cytokine storm or hemophagocytic lymphohistiocytosis. I'm also going to just quickly mention about antiphospholipid antibodies in the context of COVID infections, and just update on the current rheumatology services. I just want to let you know that please note that today we're approaching the end of May, and the guidance and even some of the things I'm talking about, new evidence is emerging, so may be only relevant for this moment in time. So firstly is a case of a lady, a 65-year-old with rheumatoid arthritis on methotrexate, Humira, and 5 milligrams of prednisolone. So she comes to the hospital with feeling unwell, with fever, cough, and breathlessness. So as usual, you would do your A2E assessment and stabilize the patient and send off the usual investigations. But more specific considerations to make are that if you think this patient has COVID-19 infection, you would stop their disease-modifying anti-rheumatic medications. So that would be the methotrexate and the biologic agent, which would be the Humira. As the patient is unwell, you would want to think about increasing the prednisolone, and I will just mention that later on, as well as to what doses you should be increasing to. And also identify this patient as having a higher risk of, potentially of having a higher risk of severe infection as they're on immunosuppressants. So if a patient is admitted with COVID infection and they're on hydroxychloroquine or sulfasalazine, you don't necessarily need to stop these DMARDs, as they're not considered to be immunosuppressive per se, but the doses may need adjusting, particularly in renal impairment. If the infections are mild, then you can continue both, but if it's moderate, then maybe just stop the sulfasalazine. So just bear in mind that if they've got an AKI, you may need to adjust the hydroxychloroquine dose. So most of the rheumatology patients will let you know that they're on a biologic agent, but beware the medication may not be in their summary care record, as usually they're prescribed by rheumatology services. So just ask the patients if they are taking any extra medications that's not on their SCR, and look up any medications you're not familiar with, as there's lots of biologic agents and biosimilars and different brand names, and it may be a bit confusing, so just look it up. But any generic names ending in MAB, think of monoclonal antibody, so Humira is adalimumab. Oh, and just as a note about biologic agents, the half-life of biologics vary, and beware that even if you're stopping a biologic agent due to concurrent infection, the immunosuppression may continue for some time. For example, if the shortest half-life anti-TNF, etanercept, will take just over 2 weeks to clear. So the next case is of a 32-year-old lady with lupus on mycophenolate mofetil and hydroxychloroquine. So she's come in with fever, myalgia, joint pains, chest pains, and breathlessness. So the first thing to consider is it a flare of her underlying condition, or does she actually have COVID-19 infection? So if you think that she's having a flare of her infection, of her lupus, you want to check compliance with medications, as some patients are worrying about taking immunosuppressive drugs during the coronavirus. Um, so in terms of this situation, if you think she's got a coronavirus infection, you would want to withhold the mycophenolate, and as long as the renal function's fine, you can continue with the hydroxychloroquine. Also consider VTE, which we should be doing for all our patients being admitted. But if she's also got a condition called antiphospholipid syndrome, which can be associated with lupus, all the more to consider VTE. And patients with autoimmune connective tissue disease also can have comorbidities such as pulmonary artery hypertension and interstitial lung disease. And also with chronic autoimmune conditions and inflammatory arthritis, these patients are at higher risk of having underlying cardiovascular disease. So this can all put them at higher risk of coronavirus infections. And just as a note, if a patient is with no known autoimmune conditions is presenting with myalgia, arthralgia, rashes, constitutionally unwell, and if these symptoms have been going on for a longer period than normal for a COVID infection, think could it be a presentation of an autoimmune condition in itself? So this table is taken from the British Society of Rheumatology guidance on identifying risk factors in our rheumatology patient cohort, which would increase their susceptibility to the virus. So a score of 3 from this table, it means that the patients need to shield. So shielding is a stricter form of self-isolation. So these patients should have their groceries delivered to them, avoid contact with people outside of their household. A score of 2, it's up at the patient's discretion to self-isolate or maintain a social distance. And score of 1 would encourage the patients to just maintain social distance and follow government guidelines as for the general population. So just to give you an idea of which of these patients do we ask to shield. So patients taking corticosteroid doses of greater than 20 milligrams of prednisolone for more than 4 weeks, patients on combinations of immunosuppressive medications, or patients on immunosuppressive medications and being over the age of 70 or having multiple comorbidities. So a patient with a score of 1, a low or normal risk, is where the rheumatic disease is well controlled and patients are not really on any long-term medications or only taking sulfasalazine or hydroxychloroquine. And a score of 2 is sort of the cohort in between. There are some gaps in the BSR guidance, which is being addressed locally, and Dr. Wajakin's come up with a more comprehensive guideline, which we have in the department and may be available on the intranet. So, for example, a factor that's not really been addressed is if a patient is having a disease flare, which is already established as a risk factor for contracting infections, as disease flare. Okay, so moving on to prednisolone, a drug commonly used in rheumatology practice, well, at least at the onset of a disease. The advice is if a patient if a patient is normally on long-term prednisolone, do not suddenly stop the long-term steroids. If a patient is on long-term steroids and their disease is under good control and they want to just reduce the steroid dose, this can be discussed with the rheumatologist or the GP, and they can have a gradual dose reduction. If you have patients admitted to hospital, say with a gout flare or pseudo gout flare, then instead of going straight for the steroids, consider whether colchicine or NSAIDs may be appropriate in that patient in the first instance. And if you're going to prescribe steroids, consider the lowest dose for the shortest time. And for example, if it's a new diagnosis of GCA or PMR or other condition where they need more than 20 milligrams of prednisolone for a few weeks, then give them shielding advice. So the table on the right just shows the general doses that we are using. So a new onset polyarthritis, you can give 15 milligrams of prednisolone daily and taper. Gout, if you can't give NSAIDs and colchicine, you give 30 milligrams a day for a week and stop. For giant cell arteritis or temporal arteritis, you start off with 40 milligrams and taper. You may want to start higher doses if they've also got jaw claudication, because it puts them more at risk of developing ocular GCA. With ocular giant cell arteritis, so threatened visual loss, these patients need to have IV methylprednisolone 500 milligrams daily for 3 days, and then high dose steroids. And where possible, consult a rheumatologist, but don't delay the IV methylpred for the ocular GCAs. So intra-articular steroid injections in the context of COVID-19 pandemic. As is usual practice, individuals with active infections must not have intra-articular steroid injections, as it could potentially cause harm to those who may be incubating. For active infections, don't give the steroid injections. But for those who don't have active infections and you want to give a steroid injection, just consider that they could be incubating the virus or become soon infected with the virus. We don't really have any data as yet to prove whether steroid injections can cause harm in terms of increased risk of COVID-19 infections. But bear in mind that joint fluid aspirations can still go ahead. It's very useful for diagnostic purposes. Obviously, if a patient has septic arthritis, we need to know about it. We need to culture the organism. If they've got a crystal arthritis, if it's pseudogout, you wouldn't really give these people allopurinol or febuxostat, but you can manage them with colchicine and steroids, whereas in gout, for long-term prevention, you would want to start them on allopurinol. So joint aspiration is still important. And also it can be therapeutic in itself. If you drain the joint to dryness, that will give patients relief as well. So there are some situations where you may want to give the intra-articular steroid injection in a non-COVID infected patient, as far as you know. It may be, but you may have to weigh up the risks and benefits and make the patients fully aware of the potential increased risk, and as there is actually a lack of clear evidence about this, so you want to just fully consent the patient. So in terms of long-term prednisolone, so you want to look at sick day rules when these patients become unwell. So the Society of Endocrinology has released guidance recently on steroid dose adjustments in the context of COVID. So normal sick day rules are usually to double the prednisolone dose when they're unwell. But due to the prolonged inflammatory process of COVID-19, the following advice is suggested for those with suspected COVID-19 on long-term steroids. So patients taking 5 to 15 milligrams of prednisolone a day can increase their dose to 10 milligrams twice a day while they're unwell. And for those taking doses above 15 milligrams, they should continue their usual dose, but take it split into 2 equal doses of at least 10 milligrams every 12 hours. So for example, if a patient is on 20 milligrams of prednisolone for a long time, they can split the dose to 10 milligrams twice a day. Or if they're on 30 milligrams of prednisolone, 15 milligrams twice a day. So just note that if patients develop GI symptoms such that they cannot take their long-term steroids, they may need to get it IM or IV. Moving on to non-steroidal anti-inflammatory drugs. So there's been some concern about the use of non-steroidal anti-inflammatory in relation to COVID-19 infection, following recent comments by French authorities. So the Committee of Human Medicines, which is an advisory body of MHRA, and NICE, they're asked to review the evidence. They concluded that for now, advice is for patients with confirmed or suspected COVID-19 to use paracetamol in preference to NSAIDs. Those currently on NSAIDs for other reasons such as arthritis should not stop their NSAIDs, because as I mentioned earlier, disease flare can also not be good for COVID infections. I'm just going to talk about viral pathogenesis. This becomes important in trying to figure out where the disease-modifying therapies that we normally use in rheumatology are being trialed now to help with this virus. So this diagram is adapted from a review article, which I found to be quite good in explaining what could be going on in the dysregulated immune system of the patients infected with coronavirus. So, this paper was mainly looking at the MERS, so the Middle East Respiratory Syndrome, and SARS coronaviruses. So the flow diagram on the right shows a protective or regulated pathway, and the flow diagram on the left shows a dysregulated or pathogenic inflammatory pathway of the virus. So there are several host factors that drive the pathology down the poor outcome or the left-hand pathway, and it's not really yet well understood. So genetics and comorbidities are emerging as risk factors for driving the pathway down the left. So just to go through the normal host response to the virus on the right, so a patient gets infected with the virus, there is not a robust viral replication, there's early interferon response to combat the virus, and the and the inflammatory cells, monocytes, macrophages, and neutrophils infiltrate the infected area, release pro-inflammatory cytokines, combat the virus. In all that fighting off the virus process, there's minimal damage to the surrounding epithelial, endothelial tissue. There's reduced vascular leakage in the lung. There's optimal T cell and antibody responses and effective viral clearance. And the patient has protective immunity and the host survives. In the dysregulated inflammatory pathway, the virus replicates and much more. It seems to evade the immune system. There's delayed interferon response, and there's a lot of inflammatory cells in the area, and these cells produce a lot of pro-inflammatory cytokines and chemokines over and above what's needed to combat the virus. And in all this battle against the virus, there's enhanced epithelial endothelial cell damage, increased vascular leakage, suboptimal antibody responses, impaired viral clearance, acute lung injury with compromise of gas exchange, acute respiratory distress syndrome, and can sometimes lead to death. So the blue triangles I've added in is to sort of represent what is thought to be going on in the patients with the severe COVID infections. So at the beginning of the illness, the virus is doing the damage. So the blue triangle, majority is viral damage. But then the dark blue triangle starts, which is where the severe immune response starts and propagates and gets worse and causes the damage in the lungs and perhaps elsewhere in the body. So the green arrows are points at which different treatments may be able to help. So the top arrow is in terms of trials looking at treatments that combat viral replication. The middle green arrow is perhaps where drugs or combination of drugs to attack both the virus and to subdue the overactive immune response. And the last arrow is probably where tocilizumab is hoped to be working, and other treatments as well. Trials are looking to see if these other treatments are working in these patients with what we think is maybe a severe immune response happening. So hopefully we'll get some answers from clinical trials. But what I'm going to do is just touch on 3 medications for the sake of time: steroids, hydroxychloroquine, and tocilizumab. So these medications we commonly used in rheumatology practice, but looking at the trials of these medications in patients with COVID. There are other immune therapies being trialed, so JAK inhibitors such as baricitinib, IL-1 blockade, anakinra, complement inhibition, the TACIT trial run in Cambridge, it's been one of the centres, intravenous immunoglobulins, immunomodulators, stem cells, convalescent plasma. So there's a whole range. So I hope to just give a brief summary of what I could find for the evidence out there for these drugs in coronavirus infections. And hopefully more evidence will be emerging soon. So looking at the looking at the use of steroid trials and coronaviruses. So theoretically, corticosteroids could have a role in suppressing lung inflammation. So steroid trials from done in severe acute respiratory syndrome, SARS, coronavirus, and MERS, Middle East respiratory syndrome, have not shown benefit in using steroids, and actually can cause more adverse events. So I'm just giving two examples. So in SARS, Lee et al. Compared the plasma SARS coronavirus RNA concentrations in ribavirin-treated patients who received early hydrocortisone therapy at doses of 100 milligrams 3 times a day with those who received placebo. So there's no demonstrable clinical benefit, and in fact there was delayed viral clearance. And in MERS, Arabi et al. Gave steroids 3 days into ITU stay. There was no mortality benefit and delayed viral clearance. So just straying a little bit away from coronavirus and looking at influenza virus. So Ni et al. Did a systematic review and meta-analysis of the effect of steroids on clinical outcomes in patients with influenza. And the outcomes in this graph on the right, just in this table on the right, shows mortality rates. So the left column lists all the studies, and the other columns show the events such as deaths in the corticosteroid and control arms of the studies. The diamond, the black diamond at the bottom, indicates the overall estimates from the meta-analysis. So so in the influenza patients who were all given steroids, there was a 1.75 times more likely to die than those who didn't receive steroids. I just want to say that none of these studies are actually randomized control trials, so they may very well be selection bias. So basically, perhaps the sicker patients were the ones getting the steroids. So the World Health Organization, the WHO, states that corticosteroids should not be used for COVID-19 lung injury outside of clinical trials. Moving on to hydroxychloroquine. So this has received a lot of media attention. So it is a derivative of chloroquine, and hydroxychloroquine has been used for many decades to treat malaria and rheumatological diseases such as lupus and rheumatoid arthritis. So it's been shown to have antiviral activity against SARS-CoV-2 in cell culture, so in vitro. And just to touch on its side effects, so when we prescribe hydroxychloroquine to our rheumatoid patients, we warn them about GI side effects, ocular toxicity and long-term use. But perhaps more relevant in the acute unwell patient setting is prolongation of QT. And I think in some of these trials, the hydroxychloroquine doses were much higher than what we would normally give our rheumatology patients. And just to bear in mind, it is renally cleared, as mentioned before, therefore dose adjustments need to be made in renal impairment. So the current evidence so far, I mean, there is no evidence that shows that it's been hugely beneficial. So more data is being gathered. So really at the moment it's unclear whether it is beneficial in COVID-19 or not. So this is a table of clinical studies of hydroxychloroquine use in COVID-19. So the first column looks at the study type. The first couple of columns looks at the study type. The next is the treatments, the duration of treatment, whether control groups were used, then the primary outcomes that the trials were looking at, and whether any of these patients ended up in the intensive care unit. So the first couple is by a French team led by Gautret et al. And it looked at the first one looked at 20 patients with the virus, with the coronavirus, COVID-19, who received hydroxychloroquine, and then 16 controls had the virus but didn't receive it. At day 6, 70% of those who had the hydroxychloroquine had a negative viral PCR swab, compared to 12% of the control group. But I must say that the majority of the patients were shown to have upper respiratory tract infections with normal CT, and also 6 of the 20 who had hydroxychloroquine also had azithromycin. Also of note is that the sample size is quite small. The same team went on to look at clinical outcomes of 80 patients who they gave hydroxychloroquine and azithromycin. The outcomes were again were to look at how long it took for patients to clear the virus using as in how long it took them to have a negative PCR, length of stay, and adverse events. So they didn't have a control arm, and they just looked at general trends in the literature of COVID-19 infectivity, adverse outcomes, and concluded that their cohort of patients who had received the hydroxychloroquine and azithromycin had better outcomes. And actually this time there's more of a 50-50 split with those with upper respiratory tract infections and those with a lower respiratory tract COVID-19 infection. And also the majority of these patients had low new scores, so it's difficult to extrapolate this to the more sicker patients. The next study, however, is now a randomized control trial of a relatively small sample size of 30 patients. So Jun Chen and colleagues, they didn't find any significant difference in the nasopharyngeal viral clearance on day 7 when given hydroxychloroquine when compared to local standard of care. Zwei, Chen and colleagues did another RCT which showed that hydroxychloroquine treatment was associated with a shorter time to clinical recovery in terms of temperature and cough than placebo. But again, this cohort of patients had mild disease, so it can't be extrapolated to more unwell patients. And finally, Molina and et al. Looked at viral load, but questions remain about whether viral load in itself is important in the critically ill COVID-19 patients, or whether progressive lung involvement is related to the inflammatory response, as I mentioned earlier. So looking at IL-6, so if I just go back to here. So where does IL-6 come into play? So so the studies were looking at IL-6 and presuming that what's driving the pathology at that point in time in the patient's illness was the severe immune response. So IL-6 is basically a cytokine which has both pro and anti-inflammatory effects. It promotes T cell activation, B cell differentiation. So IL-6 goes to hepatocytes and hepatocytes release CRP. So it's thought to be a key player in the cytokine storm, which I'll go on to talk about. So studies in China and previous studies in MERS and SARS coronavirus infections show elevations in inflammatory cytokines and IL-6 and the patient's serum and from lung biopsies. So this is a table from a study by Quinn et al. Who examined the immune response in 452 patients in Wuhan with COVID-19. Those with more severe infection expressed higher levels of IL-6, and this correlated with more adverse outcomes. But what isn't proven is whether this rise in IL-6 is an epiphenomenon, or is it actually a key player in the pathogenesis of this condition, as it's postulated to be. So the IL-6 inhibitors that we commonly use in rheumatology practice is tocilizumab, and also another IL-6 inhibitor is sarilumab. So tocilizumab goes by the brand name of Actemra and is a recombinant human anti-IL-6 receptor antibody. So tocilizumab binds to, but it doesn't activate the IL-6 receptor. So it basically prevents the cytokine IL-6 from binding to its receptor and causing the downstream effects. So in the rheumatology context, we use it in rheumatoid arthritis, as IL-6 was found in abundance in synovial fluid of inflamed joints. It's also used in giant cell arteritis and systemic onset juvenile idiopathic arthritis, or STILS, which is the most rare form of the juvenile idiopathic arthritis. So the systemic features in this condition is fever, rash, and large lymph node splenomegaly, and obviously the inflammatory arthritis. And a complication of STILS is development of macrophage activation syndrome, which is a type of cytokine storm, which I'll talk about later. So tocilizumab is given intravenously or subcutaneously. I've written here contraindications or active severe infection. So what I mean by this is in the rheumatology cohort. So if a patient with rheumatoid arthritis on tocilizumab is admitted to hospital with a pneumonia, with a bacterial pneumonia, we stop the tocilizumab because at that point in time, the thinking is that actually is the pneumonia that's driving them to become unwell rather than a dysregulated immune system. The side effects of toci, upper respiratory tract infections, headaches, elevated ALTs. The serological findings, they can cause elevated ALTs, neutropenia, elevated lipids, and low platelets. So we do routinely monitor this in our patients. So one of the earliest studies looking at the effectiveness of tocilizumab on patients with COVID-19 was from Xu et al. So they observed 21 patients over 9 days who received tocilizumab. The first table shows, on the left, shows the clinical state of the 21 patients pre-toci. And you can see that 2 had invasive ventilation and 1 out of the 20 had non-invasive ventilation. And the second group of graphs on the right chart on the top left, the fall in CRP, marked fall in CRP by day 1, day 2, after giving the tocilizumab, fall in temperature, which is graph B, the fall in oxygen requirements, graph C, and improvement in the patient's oxygen saturations in graph D. There are limitations of the study. They didn't have a control group, and it was a very small sample size, and these patients didn't really have any significant comorbidities. So going through to the IL-6 inhibition a bit more. So the previous study resulted in Sanofi doing a trial of sarilumab, which is another IL-6 inhibitor, also known as Kevzara. So this is an ongoing phase 2, phase 3 trial evaluating the effect on sarilumab on hospitalized patients with severe and critical COVID-19. And so severe patients were those requiring oxygen but without need of ventilation, whereas the critical patients were the ventilated ones. And so these groups of patients were either given placebo or sarilumab at a dose of 200 or a higher dose of 400. So So sirolimus had no notable benefit on clinical outcomes when combining the data from severe and critical groups versus placebo, but there was a negative trend in outcomes in the severe group, while there was actually a positive trend for outcomes in the critical group. So the trial may show some more results in June, and I think they're only now working on the critical demographic. So it begs the question, why didn't sirolimus work as well in the non-critical group? Is it to do with treating at the correct time of illness when the pathology switches from viral clearance to cytokine-driven inflammatory process? Hopefully we'll see more data to answer this question. So moving on to the cytokine storm or excessive cytokine production. So again, I just want to emphasize that the majority of COVID-19 patients do well, but a small group become very unwell. And some of these patients may have this cytokine storm, which induces a hyperinflammatory state, causing multi-organ dysfunction. So what's already out there, what conditions already established as causes for cytokine storms? So examples are graft versus host disease and perhaps systemic inflammatory response syndrome, SIRS, in conditions such as severe pancreatitis, which can cause ARDS. So the heme oncology specialists will probably be more familiar with the cytokine release syndrome, which is the complication of chimeric antigen receptor or CAR T cell therapy, and also in the context of also using therapeutic antibody treatments for cancers. So just to mention quickly about the CAR T cell therapy. So T cells are harvested from people, genetically altered by adding a receptor that can better recognize the cancer cells and then injected into the patient. And the T cells multiply, and when they find the cancer cell, it destroys it. And part of the mechanism of this is via production of cytokines. So a complication of this therapy is cytokine release syndrome, and treatment for this, from what I understand, is what they give is IL-6 blockade and steroids. So what I'm a bit more familiar with is hemophagocytic lymphohistiocytosis. So I've seen a handful of cases of this in the context of a rheumatological condition. So S stands for secondary. So secondary HLH is basically another cytokine storm, which is a little bit more clearly defined. So it's associated with, it can be associated with viral triggers, particularly the Epstein-Barr virus, and hematological malignancies, such as lymphomas, and rheumatological conditions can trigger it, such as Stills. And MAS stands for macrophage activation syndrome, which is what HLH is called in the context of an autoimmune driver. The primary HLH, or hemophagocytic lymphohistiocytosis, is mainly found in children with genetic abnormalities. So in HLH, macrophages, so just talking about what's happening. So macrophages become activated by a trigger, so viral autoimmune, and they secrete excessive amounts of cytokines, ultimately causing severe tissue damage. So the natural killer cells or cytotoxic T cells fail to eliminate the activated macrophages. So this lack of normal feedback regulation results in excessive macrophage activity. So in addition to antigen presentation and cytokine production, these macrophages also phagocytose host cells, referring to eating up of host blood cells. So although hemophagocytosis can be a marker of excessive macrophage activation and supports the diagnosis of HLH, hemophagocytosis alone isn't pathognomic and isn't actually required for a HLH diagnosis. So sometimes in these very unwell patients, it may not be appropriate to be doing bone marrow biopsies. So talking about the cardinal features of secondary HLH, so they include unremitting fevers, hepatomegaly, splenomegaly, lymphadenopathy, bleeding, central nervous system disturbance. And in terms of blood results, the trends you see is markedly elevated ferritins, pancytopenia, falling platelets, transaminitis, high CRP but with a falling ESR, coagulopathy, high LDH, high triglycerides, low fibrinogen, and you can send soluble CD25 or IL-2 receptor alpha to tertiary centers, and it's a marker of T cell activation, but this may take days for that to come back. So ferritin in tens of thousands range makes HLH probable, sort of in the thousands to 10,000 it makes HLH possible. But at that time, you also need to look closely at the cytopenias, the transaminitis, and other signs. And obviously, it would be important to exclude superadded bacterial infections or even malignancies as triggers in some of these patients. So the H score for HLH, so if you go to MD Calc, you can put in all the values. So you can put in the temperature, whether they've got organomegaly, and whether they've got cytopenias, the ferritin values, triglyceride values, fibrinogen values. And again, here you can see there's, you can input if they've had a bone marrow, whether there's hemophagocytosis, but it's not necessary to do it. So you can input the values. So HS score greater than 169, for example, is quoted to have a 93% sensitivity and 86% specificity for HLH. So the cytokine storm in COVID-19 seems to be yet not clearly defined. So it's postulated that small percentage of COVID-19 patients fit in with HLH with multi-organ damage. But more of the COVID-19 patients, the cytokine storms, they only have a modest ferritin elevation, and the hyperinflamed lung is predominant. So in HLH data gathered from other conditions, only 50% of those patients have ARDS. And you can see that ARDS is not part of the criteria. So the cytokine storm in COVID-19 isn't yet clearly defined, and it's worth considering, however, in the sickest of patients, whether they are developing HLH, and hopefully further data gathering will help answer this question. So I'm not a pediatric rheumatologist, and I don't have experience of inflammatory syndromes in children, but this slide is mainly to highlight that cytokine storms are very rarely seen in children who may have been exposed to COVID-19. So Europe and North America have described clusters of children being admitted to intensive care units with multi-system inflammatory condition, which has features similar to those of Kawasaki's and toxic shock. So as from medical school, you can probably remember that Kawasaki's is characterized by a medium vessel vasculitis, particularly affecting the coronaries, mucocutaneous symptoms like strawberry tongue, fevers, rashes, swollen cervical lymph nodes. And these children are treated typically with intravenous immunoglobulins, steroids, NSAIDs. This syndrome, this hyperinflammatory syndrome in children is actually reported to be rare, and outcomes are generally good. So the initial hypothesis is that the syndrome may be related to COVID-19 because initial lab testing shows positive serology in the majority of patients. And the preliminary case definition that I've put on the right is from the WHO website. So that reflects the clinical and lab features observed in children reported to date. And finally, I'm just touching on a case that I saw on the ward early on in the pandemic. So So an increased risk of venous thromboembolism has already been seen in patients with COVID-19 infections, but this case made me think of the relevance of testing for antiphospholipid antibodies in COVID-19 patients. So these antibodies are relevant in the syndrome of antiphospholipid syndrome. So this is a multi-system autoimmune condition where you need to have clinical criteria of vascular thrombosis and/or fetal loss, and is associated with persistently elevated antiphospholipid antibodies. So that's lupus anticoagulant, beta-2 glycoprotein, and anticardiolipin antibodies. So usually, when they say persistently elevated, these antibodies are repeated 12 weeks from initially detecting them. So the case that triggered my inquiry into this was of a 65-year-old patient with hypertension, Asian male, admitted a couple of months ago with a past medical history of hypertension. He was admitted with COVID PCR positive pneumonia and CT findings typically showing COVID pneumonia. And he also had subsegmental PEs. So throughout his stay, he was unwell with fevers, raised inflammatory markers, deranged LFTs, ongoing oxygen requirement, and he was tested for antiphospholipid antibodies, which were modestly elevated in beta-2 glycoprotein and anticardiolipin antibodies. So he didn't actually have any symptoms or signs of connective tissue disease. There was no previous history of thrombosis, and there was no relevant family history. So he was discharged on a DOAC for PEs, and we will be repeating his antiphospholipid antibodies 3 months after discharge. So it was not felt that he had antiphospholipid syndrome, basically. So a case series of 3 patients in China and 1 study in France had suggested a role of antiphospholipid antibodies or lupus anticoagulant in patients with COVID-19 pneumonia and thrombotic complications. But we know that infection can trigger production of these antibodies, which don't necessarily mean that they're clinically significant and may just be an epiphenomenon. So the best evidence I could find to answer my clinical question was from Galliano Valli and team in Madrid, who did a prospective observational study looking at all patients admitted to their hospital in Madrid over a 3-week period with PCR or CT diagnosed COVID-19 pneumonia, and with symptomatic and radiological evidence of DVT and PE. So they were screened for antiphospholipid antibodies, beta-2 and anticardiolipin. They were not tested for lupus anticoagulant as they were quickly put on anticoagulation. So of the 24 patients identified with COVID and VTE, only 2 had weakly positive antiphospholipid antibodies. So it suggested to me that the presence of antiphospholipid antibodies is not frequent among patients with COVID-19 pneumonia who suffer VTE. And so I felt that other mechanisms for thrombosis may be in play. The study had some limitations. They recruited hospitalized patients in non-ITU setting, so this may not be representative of the whole COVID-19 patient cohort. And we don't actually know the prevalence of antiphospholipid antibodies in the non-VTE patient population of Madrid. So the American Society of Rheumatology recommended against routine testing for antiphospholipid antibodies in COVID-19 patients with VTE unless it was clinically indicated by prior medical history or as part of a research protocol. So in the patients with antiphospholipid syndrome in rheumatology, we usually put these patients on vitamin K antagonists such as warfarin, because the ones that are put on DOACs seem to have a higher risk of getting another VTE, just as an aside, thought for consideration. So finally, what is happening in the rheumatology services at the moment with COVID-19? Again, this is the end of May, so things may change. And So we still have, we do our referrals via the rheumatology referrals email, so email referrals to us, and we see the patients. So this is the second email is for Elizabeth Warner, who's a research nurse. So as I mentioned, we need to know which of our cohort are at higher risk of COVID-19 infection. So if you come across any patients with autoimmune rheumatic disease who is likely to have had COVID or proven COVID, and who is happy to be contacted by Liz, please can you email her the details of the patient, so name, hospital number, a contact number, and whether they're happy for us to contact them. And that would be hugely useful and helpful going forward. So heart clinics, so we're running face-to-face clinics for our emergency patients, such as those with giant cell arteritis, connective tissue disease, or patients who are already known to us in the community, who are having disease flares or complications. We are still running the early inflammatory arthritis clinics, and the nurses are working very hard at getting through the patient helpline. As I mentioned earlier, Dr. Vijay Kuhn, head of our department, has come up with a more comprehensive risk assessment for identifying our vulnerable patients. So that may hopefully be put up on the Trust website. And we have already been sending out shielding letters and phoning patients. So in summary, we've gone through some specific considerations to make when approaching a patient with rheumatic disease who may have an infection. I've gone through some national guidance on the use of steroids and NSAIDs. Briefly gone through the BSR guidance on how to identify a more vulnerable patients who need to shield. I've talked about the immunopathology of what could be happening in a small proportion of our patients infected with COVID-19, so the cytokine storm, HLH. I've summarized briefly the evidence thus far on hydroxychloroquine, steroids, and IL-6 inhibitors in coronavirus infections. I've touched briefly on the relevance of antiphospholipid antibodies and on our services. I personally found useful to bear in mind advice that I've received through the years of training, that I found useful when working in this pandemic, to keep an open mind, to consider differentials all the time, do no harm to the patient, practice using the evidence we already know, gather more evidence, escalate, collaborate, and try and keep up to date. Thank you for all your help. Thank you for listening, and keep safe.